Thank you so much for joining us for the third day of the HS Awareness Week Virtual Summit. I am so grateful that you all are here again. Today, we are going to get into a very robust conversation about surgery for HS, talking about the different procedures, along with what the benefits are. Before we get into introducing Dr. Goldberg, I would love to thank our sponsors of this event. We would not be here without you. Thank you to UCB. Thank you to Hydraware, My Magic Healer, Designs by Muriel, 100-page journals, and Burt's Bees. Thank you so much for your investment in this event. We would not be here without you. And then also thank you for everyone who is here. We would also not be here without you. So we appreciate everyone who has been involved with making this happen. Thank you so much. So without further ado, I want to introduce Dr. Goldberg, who is going to lead a conversation about surgery for HS. Welcome.
Hello, thank you for having me. It's really a privilege to be here today to speak to all of you. I honestly wish I could see all of your smiling faces. One day I hope we'll be able to do something in person rather than virtual, but I'm trying to envision you on the other ends of the screen. So I'm a surgeon. I'm also Associate Dean for Graduate Medical Education at the healthcare system where I work, which is Mary Washington Healthcare in Fredericksburg, Virginia. It's about 45 minutes south of Washington, D.C. and north of Richmond, Virginia. And I do run an HS surgery clinic and have specialized in this area for many years now. Today, I'm going to talk to you about the role for surgery in HS, discuss the procedures performed in the clinic versus the operating room, go over the different types of surgical procedures, goals for procedures, help empower you with some questions that you might be able to ask when you seek surgical evaluation or determine whether or not it's appropriate for you to even go see a surgeon, and then talk to you about a little bit about what makes surgery a success. And I am going to show some pictures. I do want to make certain you understand that all patients whose pictures are shown have given their permission. There's no identifying factors in any of these, so you won't be able to tell who they are from looking at the pictures. The other piece is that I know people can react very differently to pictures. So if you tend to be a bit more sensitive to some of these images, I did try to limit them to things that I thought would be a bit easier to grasp, but I'm going to apologize in advance. And if anyone has any concerns or if this impacts them in a negative way, that's not my intent. So please don't hesitate to reach out on the side and I'd be happy to speak with you. All right, so why do surgery for HS? Well, I'm going to ask that you shift what you may have been previously told in the past. And a lot of the role for surgery in HS so far has focused on recurrence rates. How can we decrease recurrence rates? What are the chances that this is going to come back? And of course, that's really, really important. However, there's more to it for people who are living with HS, because as we know, this is a chronic systemic disease. And as much as I would love for surgery to be a cure-all for everyone with HS, the reality is that it's a tool that's used in combination with other modalities. And we can pivot our thinking in terms of what types of symptom relief and quality of life can surgery help us with. And it's going to be different for everyone. So that's really important. So you are the only one who can really grasp how HS impacts your own life and what your priorities are accordingly. So it could be that you're looking for decreased pain or decreased drainage or decreased infection or the ability to engage in more social and professional interactions. Ultimately, the role and the goal of surgery is going to be driven by you and what you are looking for from surgery. So on that note, it's really important to establish goals of care. And this is something that you should think about before you go to meet with your physician and then have that conversation when you meet with the physician. One of my favorite things to ask patients when they come in is, what is the goal of your visit today? And that's even with surgery. It also helps me understand whether or not we can be on the same page and we can move forward to a place where the person who's living with HS will be happy with the outcome. And because we do want to set realistic expectations, the last thing we want to do is do surgery and then have it not meet an expectation and have gone through all of that. So why do some people not want surgery for HS? Well, of course, I just about the recurrence issue. There's some that think, well, if it's going to come back, or if it's going to come back in a different area, then why should we do it at all? The time off of work and the impact on your family and your personal responsibilities is pretty significant. So we also want to make sure that the timing is right, the support systems are in place, and work with you to figure out what that might mean for you. And then there's the pain. People living with HS are often in pain. And the whole concept of pain in general, and even a different type of pain, a surgical pain, can be absolutely frightening. And surgical pain is very different, as is HS-related pain for different people. So we have to work through that as well. And then, of course, that fear that it just won't work. And that lack of hope can also be a barrier for someone not to have surgery for HS. So we know in general that surgery works best when it's combined with medical management and lifestyle modification. And there are different entry points that people with HS can come into seeing a surgeon. Oftentimes acutely, if they're having a flare or an abscess, they may meet a surgeon in the emergency room or a urgent care setting. They may seek surgical treatment because of as their primary modality for treatment without having access to dermatology. Or it may be that they're working with a dermatologist who then says, you know what, let's bring in surgery. Let's have these conversations and see if surgery could work for you. So the concept of surgery is really broad. And I know it can be incredibly confusing, not only to people living with HS, but also to physicians. So I want to simplify it for you as much as possible. And I'm going to ask that you think of 3 surgeries, okay? 3 different techniques. And the reality is there are literally only 3 techniques that we use for HS surgery. Anything else that you hear of is really a variation of one of these techniques, but it can be put into one of these 3 categories. And we're going to go through each of these one at a time: incision and drainage, de-roofing, and excision. So where can these 3 things be done? Well, the reality is that they can be done in a clinic setting. Okay, and the clinic setting is incredibly valuable. It can be done oftentimes by dermatologists, by dermatologic surgeons, by other types of surgeons. Small areas are great for a clinic. They are typically anesthetized, where the skin is injected with numbing medicine, and the patients are awake in this setting. I will say there's one caveat to all of this, is that if there is an active infection or abscess, it can at times be very hard to numb it up and to get good analgesia. This is not always the case. It has to do with the pH of the abscess area and the skin around the abscess relative to the injected anesthesia medication. So that would be one barrier. By the same token, understanding that some of these can be done on some scale in the clinic affords more access to care and the different options available. So the other places where surgery can be done is in the operating room at a hospital, or, for example, a surgical center. And the reason I bring up the surgical center is that a lot of times the hospital costs or the facility fees that are associated with a surgical center may actually be less than an operating room, depending on what type of insurance that you have. The operating room and the surgery centers are great for larger areas of the body or multiple areas of the body to be operated on at one time. Obviously, the location, it can be a bit more comfortable in certain sensitive areas of the body to have it done in the operating room where you can be sedated or completely asleep. That being said, you do need someone to drive you home from surgery. And you will be groggy for a day or so afterwards. So that's something to keep in mind as well, especially if you have other responsibilities at home and do not quite have a lot of help from other people to do your daily activities of living. So who performs surgery for HS? Well, the reality for this is there's a lot of physicians and providers, but you need to find someone who is knowledgeable about this, and it can be tough. So when I think about clinic-based procedures, dermatologists, surgeons, even some primary care physicians can do some of these small procedures if they're knowledgeable and understand. And then subspecialty physicians and surgeons. And the reason I bring them up is that on a lot of the groups that I'm on, I see a lot of discussion regarding, do you need a colorectal surgeon or a general surgeon or this, that, and the other? The reality is that it's not so much important to focus on the type of surgeon, but rather what their experience with HS is and what they're willing to learn and help with. A side note, though, for the clinic-based procedures is that a lot of gynecologists and urologists do have experience with this disease. So as you look for access to care, if you have, for example, a gynecologist who you see yearly and you have HS, this is a nice entry point to have a conversation with them about, what is your experience with HS? Can you help me with any of these things, and so forth? So in the operating room, the people who typically have privileges to operate in the operating room are going to be your surgeons. And as I mentioned before, they're all different types: general, trauma, colorectal, plastics, surgical oncology. And it really depends on the surgeon. One is not necessarily better than the other when it comes to choosing the training. That for the most part, with the exception of plastic surgery, the elementary basic training where they would have been exposed to HS surgery is essentially the same. And then there are some dermatologic surgeons who are dermatologists who undergo an additional year of some dermatologic surgery training beyond their dermatology residency. Some of them as well have privileges at some of the ambulatory care centers and operating rooms. So going back to the three different types of surgical procedures, we have incision and drainage, we have deroofing, and we have wide excision. And here's the interesting part. These same procedures can be done in the clinic or in the operating room, and they can be done on a small area or a larger area. And actually, now's a good time to bring up that when we share our experiences with each other about what surgery has been like, no surgery will be identical for each person, and no experience will be identical. And with the exception of a very few situations. And the reason is that everyone's disease and the way that HS impacts them, both on their skin and then also systemically, can be very, very different. So I want to draw your attention right now to the image on the right side of the screen. And you can see there's a hair follicle with a cystic type structure around it that's rupturing. And then in the middle, another cystic type structure and tunnel. And then, of course, these combined tunnels underneath the skin. And I want you to keep this pathology in mind as we move forward and we talk about the different procedures. It'll be helpful to understand the difference between all of them. So incision and drainage is the first one. And I'm going to go back to the slide for a second before. So with incision and drainage, what we're literally doing is taking one of these areas where there may be some fluid or pus or material that's accumulated underneath, and we're literally opening up the skin, okay? And it's allowing all that fluid. So for example, if we're looking at this image, all that white stuff to come out. But what we're doing with the incision and drainage is we're leaving behind that rind, okay? That thick peel, which in this image, it appears to be a reddish color. So we leave that behind. So we're not actually removing the disease in this setting. We're actually just opening it up and draining it. So why do it? Well, if you're in a lot of pain or someone's in a lot of pain or discomfort from an acute flare, and the flare is full of, or the cavity is full of fluid rather than some hard inflammatory tissue, that can provide pressure and pain relief. There's other things that we can do medically for flares as well. And a lot of flares will improve on their own. But the thing to remember with incision and drainage is that it can improve or worsen quality of life. So what do I mean by that? Well, what I mean by, for example, take this picture on the left, and there's nothing actively draining right now. All of those tunnels or and cavities are underneath the skin. But when we open it up in this setting, there's a good chance that it may not heal. Or it may heal and it may open up, and it may heal and open up. And I have seen situations where we turn a non-draining tunnel into a draining tunnel. So now someone is left with the disease, the cavity, and then something that just doesn't heal because it continues to drain. So the important thing to remember about incision and drainage is we see it all the time. It's utilized a lot, especially in the emergency room setting, because it can provide relief. There's a lot of controversy over this. I am not a huge fan. I'm not against doing it per se. Someone can twist my arm, again, for the right reason, if it's for symptom relief and so forth. But the reality is the recurrence rate for this is going to be very high. I hesitate to say 100% for one reason, but it's near 100%. And why is that? Because again, the skin closes, you have that cavity where all the material is trapped underneath. You have all of the surrounding inflammatory tissue, which is from the disease. And we're not actually removing what's driving the disease. Okay. The reason I say it's not exactly 100% is because anytime our bodies are really good, our bodies actually want to heal. And that's why our bodies try to scar and make scar, even in the setting of HS. So by opening it and us causing some trauma to the skin by opening it up, we still are encouraging a bit of scar formation. So on the rare situation, if it's been drained multiple times, it may not fill up with fluid to the same extent, but that's not the norm. So that's important to keep in mind. So let's move on to the second form of procedure, which is called a de-roofing. And this is a really fantastic procedure. And the best way to think of it is if there's a simple tunnel, and I'm going to, if we think back to the image that we had before, which showed the tunnels, sometimes the skin can be open and it can be a draining tunnel, and sometimes the skin can be closed. But the idea is that if there's a well-formed tunnel, what we can do is literally open up the tunnel so that we can see the inside of the tunnel. And there's a couple of different ways we can do this. If you look at the image in the middle, you'll see a probe. We made a hole in the skin, and there's a probe that's being inserted into the tunnel. And then in the upper right-hand corner, the skin overlying the probe is opened up and trimmed off. And then what you have left behind is the base of the tunnel. Okay, the base of the tunnel with, remember that red rind that I talked about a few slides ago? That's actually what you're looking at right there. And that is this gelatinous inflammatory tissue. And underneath that is this, for the most part, is this nice base of healthy tissue that will heal. So we go in and we remove all of that red gelatinous material, which is in that second image on the right-hand side, and then you'll see how it closes up very nicely. Now, deroofings can be done on a small little tunnel in the office, or the way I use them in the operating room, because I have the benefit of making people comfortable in the operating room, is really chasing through a lot of complex interconnected tunnels to try to minimize trauma to the underlying good tissue. Okay, and I'm gonna go back a few slides for a second to the image of that we had, which showed the HS. So a deroofing in this case, if we look, for example, at the picture on the right-hand side, where you can see the tunnels, where the label for the tunnels points to, we would be going in the skin, finding that entire tunnel, taking off that top layer. So deroofing, like taking the roof off of a house, and then removing not only the white stuff that's inside in this image, it's not white in real life, but also that red gelatinous material underneath this. So what's the benefit of this? Well, the benefit of this is that we're taking out less tissue and we're causing less cosmetic disfigurement and deformity. So hold that thought. And let's go back to the wide, let's move on to the wide excision, and then we can always come back to talk about that in a little more detail. And so I can explain what I meant by that. So I'm going to move ahead to excision. All right. So the third procedure is excision. And you may hear a lot of terminology about a wide excision or a partial excision and what margin are we taking. That's a tricky thing to talk about. The concept of excision really comes from cancer surgeries that were done where we looked at recurrence rates for certain skin cancers and whether they were higher or lower, depending on how much additional tissue around the lesion or the cancer is taken. Well, HS is different. So why is HS different? Because it is a chronic systemic process rather than the skin cancers, which tend to be more focal in nature. So there are a number of different approaches we can take, but the one thing I want to point out to you in general is that the difference between excision and deroofing is that excision involves us going down to the fat. Okay, so for example, this is an armpit on or an axilla on the left axilla. And what I've done here is I've drawn a picture around it, but if you take a closer look, when I go through and I excise, I drew around it for the purposes of the patient while we were having that discussion, but I can't necessarily see what's going on above the skin until I start cutting through. And most of the time, not all of the time, I can tell where we've hit a part which is grossly diseased or like visibly to the naked eye diseased versus skin that appears somewhat normal. Now, this doesn't mean that you couldn't develop more HS and more disease later on down the line. It's incredibly possible. However, the hope is with the combination of medical and surgical management, we can navigate this and try to mediate that. And I'll explain a little more as we move forward with the healing process about why I do things the way I do them and how I think it could influence some of the recurrence rates as well. But the most important thing with excision is that we're going down to the fat. And when you think about your body and when you think about contour to your body, it's really the fat that gives you contour. I hope no one takes this the wrong way, but breasts, for example, breasts are fatty tissue. Buttocks, not the muscles, but outside the muscle, that's all fatty tissue. That helps give you your shape. Now, so one of the things that I like about deroofing is that I'm not going into that subcutaneous fatty tissue. Okay, so I'm going to go back to the image right here that we talked about before. So the three procedures, incision and drainage, would just be literally opening up the skin and draining the white. Deroofing would be finding a tunnel, opening up the tunnel, taking off that top layer, not only removing the white fluid that might be there, but then also that red gelatinous material that's causing and driving that disease. Wide excision would be us not actually going into the tunnels, but instead cutting around the tunnel. So taking out a larger chunk of tissue. So we'd be going wider than the red margin around the tunnel and going into that subcutaneous fat. So I'd hope that gives you a nice framework to how to think of all of these things, and then understand that all of these things can be used on different levels in the clinic or in the operating room. So with that theme, everyone's different and not all surgeries are the same. So when you're talking to people about the types of procedures or surgeries they may have had, you may be taught using the same language, but it may not have been the same thing. So for example, axillary excisions, well, was it a complete excision? Was it a partial excision? Deroofings, was it one small tunnels? The reality is that the way this disease works is that it's not impossible. And often some people will have one tunnel, but as the disease progresses, it becomes this maze and network, or it can become this maze and network of interconnected tunnels. So, and it's not just a straight tunnel. So oftentimes when I'm operating, I'll start with a tunnel that looks very formed, but then I see side pockets, side tunnels. Some of them are very small that are coming off. And unless I address those, we're setting ourselves up for that recurrence. Even then, we still may be setting ourselves up for that recurrence, but we'll talk about that shortly and why I think we should pivot away from the term recurrence. There's also, of course, we talked about the partial excisions and then the deroofings of the different areas. So just keep that in mind and ask those questions when you're speaking with people and when you're speaking with potential dermatologists and surgeons about what your surgery can look like. All right, so we just established that there's three main surgical procedures: incision and drainage, deroofing, and excision. Okay. Now I want to talk about the different tools that we use to do surgery, and this can be even more confusing. So the reality is that we can use so many different things to do all of those three techniques. Okay, because when you think about it, it's not so much what tool we're using, it's more so what technique we're using, what the purpose is, and how we're treating the tissue or the disease tissue. So what can we use to cut skin? Well, a scalpel, scissors, very sharp scissors can be used. A tool that a lot of surgeons use and are familiar with, especially because it's in our toolbox, okay? It's in the operating room, it's in our clinics. That's electrocautery. And if you look at this electrocautery, this is a basic electrocautery device. It cauterizes and stops bleeding. It also cuts. So if I hit that yellow button in that middle under electrocautery, it functions just like a knife, just like a scalpel, and it cuts. And if I hit the blue button, it'll actually stop bleeding and cauterize and essentially function to some extent like a laser. And that's a nice segue into the CO2 laser. CO2 laser, there's a couple of different ways you can use it. One of which is to use it for excisional purposes in the same way that you would use a scalpel or the electrocautery cutting device or scissors, for example, and literally excise, so going into the fat and cutting out tissue. The other way that you can use it is in a refractory type of way to help ablate lesions. So that's more of a topical type of use to it. And that is a discussion. I don't want to pivot off topic too much from the CO2 laser right now, what I want you to focus on is that there's a lot of excitement over CO2 laser. Why? Well, there's a number of different reasons. CO2 laser is a staple in dermatology. CO2 laser is not as much a staple in a surgical office. Some people have it, and some people have had great experience with it and great results. It is more expensive. It requires a different type of training and so forth. So don't focus when you meet with a surgeon. If they don't have CO2 laser, that's okay. Don't focus so much on the CO2 laser part or on the scalpel part. Focus on are you going to de-roof this? Are you going to excise this? Are you going to do a partial excision? Are you planning to completely excise that entire region? What should I expect and what are our goals with that? Okay, and we can certainly come back to that if you have any questions about that later. Oh, the one thing I did want to say is that there have been some studies that look at pain as it pertains to CO2 lasers versus cautery versus knives. There are a lot of different studies out there. Some are good, some are challenged, as any studies are. So I would take that with a bit of a grain of salt right now and focus again more on what is the procedure, what is your goals for the surgery. Pain, we'll talk about pain later as well, but pain after HS surgery is really interesting and it's very different from each person. What most patients tell me that when they wake up from HS surgery is that gnawing, deep-seated HS pain, that pressure is gone. Okay, it's replaced by a surgical pain, which then decreases over time. But pain is incredibly different for everyone. There's a huge physiologic component, which is very different for everyone, as well as it's influenced by other factors as well. So we need to remember that someone's pain experience may not be the same as someone else's pain experience. All right, so let's talk about healing. We've talked about the types of procedures. We've talked about the tools that we can use to do the procedures. Let's talk about healing after surgery. So why did surgery get a bad reputation in the first place in HS? Well, the reason was when surgery was first described as early as I think it started in around the 1940s. There was a classic HS was only thought at that time to occur in the armpits. They didn't know anything more. So the procedure that was developed was called the Pollock procedure. And the procedure was cut out the armpit, sew it back up together. And the complications associated with the surgeries were pretty high. And that's where people started saying, well, surgery doesn't work and it comes back, or the wounds fall apart and so forth. But that's kind of the classic procedure that's quoted and that's taught to this day in surgical training, all the surgical training. So why did it not work well and what happened? Well, first of all, it's in an area of the body that's under a lot of tension. So when you move your arm, you're putting a lot of tension on that wound. And for wounds to heal or incisions to heal well, we need a couple things to happen. One is to have tension free, so no tension. Another is to not have inflammation. Well, we know that this is a chronic inflammatory type of disease, a systemic disease where you do have inflammation going through your body. And a lot of times the skin around the area, even if it doesn't have tunnels, may still have some inflammation. And then of course, the other thing is infection. We know that any wound that we do for any purpose, if there's tension, if there's inflammation, if there's infection, the other one is poor blood supply, which fortunately people with HS have good blood supply, but those other things are going to prevent it from healing. So the other thing that I experienced with doing a lot of primary closures underneath the arm and also in other areas is that since you have disease, potentially even microscopic disease that you can't see to the naked eye in the surrounding tissue, when the disease progresses, so I'm not going to say recurs, but progresses, What you've now done is you've created a long space for the disease to spread and to go. So it actually tends to progress along the length of the incision line. And what you end up with is a wound, which is often draining and now full of disease and painful. And sometimes it's even bigger than the disease that you started with. So for the most part, I and most of my colleagues in the HS world surgically do not recommend primary closure anymore and do not utilize it anymore. So what does that mean and how do the wounds heal? Well, we talked about before how wonderful people with HS heal, okay? And the body wants to heal. When the body is trying to fight this, they're making scar, okay? And then when we do surgery, how do wounds heal? Well, they heal by scar formation, and it's a process that takes a long time, but there's a whole process for wound healing. The first it takes about 21 days. There's different phases of it. You get collagen deposition, the wound remodels, the types of collagen change, and it turns to scar. So what are we doing with deroofing and excisional surgery? We are trying to ask the body to replace the cavity that we removed with scar that doesn't have HS in it. Okay. And there's a couple of different terms that we use for this. Secondary intention is the classic term that you might hear or read online in it's medical jargon. The other is healing from the inside out. And it's exactly the same for deroofing or excision, for deroofing, provided that it's done correctly and we remove that gelatinous material underneath to this epithelial layer, and which is similar almost to the skin that you have on you. So that being said, I've told you how I do it and what I do and how things heal. I do want to now take a step back and talk about the other options that exist other than closing the wound primarily or that secondary intention healing. We're going to get a little deeper with this, okay? So if we do a wide excision, and this is not true for deroofing now, okay, we're going to take a step back, but for the wide excision where we're going down to fat, okay, we talked about the primary closure. We talked about why I don't prefer to do them. The other things that can be done are flaps. And you may hear about this in the literature, in the medical world. You're going to hear it primarily if you meet with a plastic surgeon, for example, because they're the ones who are really trained to do the bulk of the big flaps. Flaps in HS can be hit or miss. And the reason I say that is it's those same principles of what does the disease look like systemically? What would I anticipate in terms of any progression of the disease in the surrounding tissue? And what I've seen is similar to when you close a wound, and it can occur in the incision of the primary closure, the same thing can happen with a flap, because the flap incision is no different than any other cut or incision. You're trying to promote the wound healing, scar forming, and you have all of those same things in place, including potentially surrounding inflammation or residual infection that can impact it. And sometimes you can end up with a worse problem than you had. Have I seen patients who benefited from flaps? Absolutely. But are there other options? Absolutely. So moving to the other option for wide excision healing, and I hope I'm not confusing you too much, but this is also that space that can be used for deroofings after they've had some time to heal. The body does a couple of different amazing things. Either we can take a wound and we can do daily wound care changes. There are some advanced wound care, excuse me, dressings that can be left on for multiple days at a time. In my experience, the wounds do develop a lot. They can breed a lot of bacteria and biofilm. So I change them on mostly a daily basis. So one option is to do the daily dressing chains, and literally the wounds, what happens is they heal from the bottom up and then the outside edges in, but it's a long time and it's a process and it takes time. The other option is to use something called a wound vac. And a wound vac is a really fantastic device. It is a negative pressure suction device. And I'll show you some pictures. It involves a black sponge, which you put on in the wound, and then a thin piece of plastic, and then it hooks to a machine that literally sucks all of the fluid out and helps promote the wound healing. And there's a lot of very good data to show how wounds heal with wound vacs, and that this can increase the healing compared with daily dressing changes. At the end of the day, the wounds are still going to heal, and it might be a tiny bit faster. The challenges with a wound vac is, years ago, you had to be in the hospital to have a wound vac on. So you're talking about potentially spending weeks and weeks and months in the hospital attached to a machine. Well, fortunately now you can go home with a home wound vac. It's almost like a bag that you wear over your arm, but there is a motor because it's sucking all the time. It can lose suction and allow air to get into the system, which can cause anxiety for a lot of people. And then and require a specialized nurse to come out and help you with this, which may not be able to do at night. And then the other piece is it can be incredibly uncomfortable. Okay. And then the third option for healing these big wounds that we're talking about is letting the wound heal from the inside out, up just to the skin level. So we go from the bottom up, not from the outside in, and then we put a skin graft on there. So there's pros and cons associated with that as well. There's a risk, of course, that the skin graft might not take. We do have to take skin from another area of the body to then put it on this area to close it. So you're creating another wound. There's a couple different ways we can manage the skin graft. It takes about 5 to 7 days to get a sense of whether or not it's really going to take. And when we do that, it can be incredibly, incredibly painful and uncomfortable. All right, so let's go into each of these just so I can give you a little greater sense of what they all look like. So this is an example of a primary closure excision. In the first picture, you can see the HS disease in the tunnels. In the second picture, you can see why it's an excision. You also see my dog in the background who just jumped up onto the chair. So my apologies if you saw something blurred there, but they're enjoying the talk. So what we've done is we've excised down to the fat around the tissue, and then we've closed this. And this is one of my patients. This is a surgery that I did. And I always love to highlight things that didn't quite go the way I had hoped they would go. We have some drains in here. This was a pretty big cavity, and you can develop some fluid that then forms underneath the skin when a wound is closed, and it can impair and impact the ability for the tissue to close up on itself. So in this situation, we actually have a drain in there, as well as a local anesthesia pain type of pump to help with that. And then there's some gauze on top of with some sutures. So, well, what you see on the right side is that as the wound is falling apart, the edges are separating. You can see don't look very happy. You can see the skin around the area with some progressive disease that we couldn't quite appreciate in grossly when we took out this image. Okay, I mean, sorry, took it out initially in that second image. The other issue with doing the primary closure, especially under the armpit, is that you got to keep your arms by your side. And when you go, even if you forget and you try to move it, it puts a lot of tension on that wound. It's incredibly uncomfortable and incredibly painful. All right, so what does this healing from the inside out, the secondary intention, look like? So same picture on the left-hand side, and for those two images. And then actually this is the a different patient, but the number 3 and 4 are consistent with the type of wounds we had it from the first side. So we use a dressing. And my preferred dressing is a silver alginate dressing. There are many physicians who don't use these dressings. They may use petrolatum or an antibiotic ointment, not for its antibiotic purposes, but more to keep wounds moist, because we know that wounds actually like to be moist to heal. We don't want to dry wounds out anymore. But I like the silver alginate because it's a piece of felt. I call it almost arts and crafts. So it's a matter of literally cleaning the wounds. What I have my patients do is get in the shower starting on post-op day 2. And I want the water to hit over it and run over it. I want you to wash your body with soap. You can use soap in the wound. It's good for it, okay? And then get out, pat it dry, and lay this felt on top. And I'm going to show you a video of that shortly, so you'll get a sense of what I'm looking or what that process looks like. And what's gonna, and then when it closes, I want you to compare the size of the wound that we made to what it looks like when it closes. So how someone heals and how their scar forms is to some extent genetically predetermined. So everybody heals a little differently. I have not had issues with patients keloiding with after surgery for HS. I have seen patients who come to me who have keloids in their HS, but after surgery and after removed, I haven't had any issues with keloids per se, but you can see how the wounds contract down to a scar and just how amazing the body is at moving itself or healing itself. So here's a picture of that wound vac that I talked about, and I want you to focus your attention onto the image, the second image from the left-hand side. There's a black sponge that's literally laid in the wound, and then a plastic cover that comes on top. The little suction tube attaches to it and then attaches to a machine and suctions. And you can see that's why the wound just kind of shrinks down like that. Same thing. You end up with the exact same result, which is a scar, okay? A nurse would come out to your home about 3 times a week to change this, so it doesn't involve the daily wound care. It may speed healing, but of course there are cons associated with this as well. And this is one of those things where for very large wounds or people who feel like they may not be able to manage the secondary intention healing with just the special dressings, I offer this up, or if you just ask me, we try it and we see if you like it. And if you like it, great. And if you don't like it, we move to plan B. So with the skin graft, to do a skin graft, we have to go through the process of secondary healing, secondary intention healing, building up that red base of tissue before we can put a skin graft on. Okay, so what I mean by that is that we won't go to the operating room in the same day, cut out the HS, excise the HS, and then right then and there, put a skin graft on. It won't adhere because what we need for the skin graft to adhere is a good base with good tissue, which has a lot of blood vessels in that. So what the process would look like we would do an excision, cut out that area, let it heal either with a wound vac or with the wound care dressings, and then go back to the operating room for another time to put the skin graft on. And we did talk about the challenges associated with that. The next thing I want to point out, so we've talked about now how wounds have healed. Not all surgeries need to be big. And this is an example of a person who has HS in their breast crease underneath on the left-hand side. And the nice thing about this, what I've done here is very small de-roofings throughout the entire area of areas that were bothering her. When you think about it, if we were to cut this whole area out down to the skin, There would be more of a disfigurement. From a contour standpoint, we'd be taking out some skin, which might also be good skin and a pretty big wound. But what we've done here is we've said, okay, we can see the areas that are problematic. I'm going to go in here, I'm going to de-roof these little areas and find the active spots. And the way we managed this after the surgery was just with some petrolatum jelly, which is basically Vaseline in the wounds, and getting in the shower and washing every day. And you can see on the right-hand side how it heals up. So when we talk about expectations for surgery, especially cosmetically afterwards, what we've done is we've maintained contour. We've gotten rid of the disease, and actually, in her case, her disease has not progressed, using a combination of the medical therapy to kind of keep things at bay and suppress the immune response in the background, combined with the surgery. But what she doesn't have is the drainage, the pain, or the inflammation, but she does have a scar. So that's, that's really what you would expect with something like this. And that being said, if she were to have another area that pops up in this area, either in the exact same scar or adjacent to the scar, I wouldn't be surprised. And it doesn't mean that the surgery failed, because think of the amount of pain and drainage and the challenges that she probably had before this. So the beauty of that is if it happened again in this area, we could do a small procedure in a similar fashion. And my hope is it would be much smaller than this when we were kind of playing catch up to really get on top of it. So what do you expect after surgery? That's always a hard thing. And it's hard to explain to everyone because it really depends on the type of surgery, the location of the surgery, the extent of the surgery. Is it a big area? Is it on your backside where it might be uncomfortable to sit down? Is it underneath your arm? So these are things to consider. Pain, we talked about how pain can be very variable in different people. I can't predict how much pain someone's going to have and what the pain is going to be like for them after surgery. What I do find it's interesting, even for an armpit. I've had patients come in my office a couple of days later and go, look, I can move my arm, and there's literally a big excisional hole in their arm. And then I have plenty of people who might have a lot of pain and feel very uncomfortable, and it's very sensitive. I typically say about 1 to 3 weeks. And what you'll find is that the pain will improve over the course of 1 to 3 weeks significantly. A lot of times with the wounds after surgery, they can develop this biofilm that kind of builds up. It's like a white fibrinous type of debris. And that also can increase pain, and getting in the shower and wiping it off can really improve that pain dramatically. The other thing that I hear from people is that they can have a lot of itching as the wounds heal. This isn't just true with HS, from your HS, but anytime people have surgery, a lot of times that's a common thing that we hear, and it's not uncommon. Some steroidal cream around the edges of the skin where it's itching, not in the wound, works very, very well. And as far as going back to the pain for a second, I'm a big believer in ice. I think ice works really well to help numb the area. A lot of people do find relief from a bathtub or a shower, and that's not going to cause the wound to get infected. The beauty of keeping these wounds open is that they don't get infected by definition. Now, when I say the infection, you don't get that deep abscess infection. You can get the biofilm or bacterial overgrowth that can occur, but that's much easier to manage. So let's talk about the daily wound care if the wound is left open, and what to expect and what you need. Well, it would be done by a family member or yourself. And interestingly enough, people with HS are more skilled at wound care than most people in the healthcare field. It's an unfortunate reality of the lives and some of the challenges that you've had. And I've gone through phases where I've set up home health nurses to come out to homes to help people with wounds. Interestingly enough, a lot of the wound care nurses, and we're not talking about wound care nurses who work in a wound care clinic. We're talking about different levels of experience, people who come to your home. A lot of them have never seen these types of wounds before, and they're very, very difficult for them to manage. And you are actually, or your family member is more comfortable. So the way I approach this is when I see people in my office to discuss surgery, I do ask they bring a family member with them to that visit so that we can talk about what it's going to look like. And then depending on the type of information they feel like they need at that time, we either talk about it then and there, but a lot of times we wait till after surgery. And after surgery, the day of, with permission, of course, from the person undergoing surgery, I sit with the family member and I show them the before pictures, and then I show them the after pictures, just like I showed you in this, just so that they can see it with me. So if it's any shock to the system, if they have any response to it, I'm there with them to help them say, this is okay and this looks okay. And then we go over how to do it and how to do things. The next piece of the daily wound care is showering is really good. I want you to get in the shower. I want you to wash the wound. I want you to use a washcloth and soap. You don't need any fancy soap. I'm a big fan of just your regular bar soap. What's more important here is to manually or using your hand clean out the wound. The other thing to talk about, though, is the time to heal. And, obviously it's different than if you just close the wound. Skin in general, if we do surgery for non-HS things, skin typically heals and closes after a couple of days, and it becomes a bit more watertight. It's different if you have a big wound, right? Because that's going to take time, and it's different for everyone. For a little wound, it may just be a couple weeks. For a big wound, it may 4 months. And for an even bigger wound, it could be 4 to 5 months. But the thing to remember here is that it doesn't mean that you will be debilitated for that long. It's typically about 1 to 3 weeks where you'll probably be a bit under the weather. And I basically say, you'll know when you're ready. Activity is tolerated. Get up and move around as much as possible. You can go back to work when you feel up to it. You're not going to hurt it. You're going to have a dressing under your wound. But what I find is that it's really replacing one type of dressing that you had before surgery for another type of dressing after surgery. But it does require a lot of patience, and it's a bit of a journey, a marathon, and knowing that this isn't a quick fix. The easy part is doing the surgery. The longer part that takes more patience is the healing part. Going back to the theme that wounds take about, or the scar formation takes about 21 days, I typically see a difference in the wounds after about 3 weeks. So I like to see pictures or the wounds in person every 3 weeks, just so I can eyeball it and say, looks good, let's keep doing what we're doing, it's healing appropriately. Or, you know what, let's change up the wound care. Maybe this isn't working for you as well. Or let's give it, I call it giving it a little love, maybe to clean it up a little more. So this is an example of what to expect after axillary excision down to the fat, where it's healing from the inside out from a timeline standpoint. So the middle picture is, and I recognize this is a bit graphic like the others before, so I apologize if it's uncomfortable for anyone. But the middle picture, you can see the fat. 3 weeks later, you have this red tissue in there. And this is different tissue than you would see in an HS tunnel that we had on that image before, that jelly material. This isn't jelly material. This is granulation tissue. There are times where I hear people referring to the tissue in the tunnels as granulation tissue. It is not true granulation tissue. This is different. This is healthy tissue that has a lot of what's called angiogenesis going on, with a lot of blood supply. It's very rich tissue. The stuff that you're seeing on top of that is not bad either, that little whitish debris there. So this is healing really beautifully. And what I want to call your attention to is in those 3 weeks, you can see that it's really filled in nicely from the depth from the bottom. It's not completely skin level yet, but you also see the edges are very slowly, where it's kind of come up, where the depth has filled up. The edges are starting to come in and the scar is starting to deposit. So here's a video, let's see if this works, of this same patient 3 weeks after her surgery who came into the office for her check.
This is a picture of a wound that was excised and is now 3 weeks after surgery. What you can see is that the red tissue is good healing tissue. Once you remove the dressing, it's important to either shower and bathe. You can use regular soap and wash your hair like you typically would. It will not hurt the wound. If you are not showering or bathing at that time, you can drip some saline over the wound to wash it. And this can be done by using a syringe or pouring some saline over the area.
And you see how
if there's any whitish debris on top, you can also gently rub the wound.
Not true for everyone.
And that will remove some of that outer layer to help promote wound healing. When that's done, we will place the silver alginate dressing, which is the felt-like dressing. You should cut it to fit the wound so that you can save the extra and use it at a later time. However, it is okay if the edges touch normal skin. After this, place a piece of gauze folded up in the wound to help promote contact. And then place an absorbent dressing or additional gauze.
That's purely for comfort, or if you have a lot
Followed
of
by
drainage,
some
these can be incredibly uncomfortable. Excuse me, the absorbent pads, they can feel incredibly awkward. So hopefully that gives you a sense of what the wound care looks like once you're out of that acute post-operative phase. And here is a picture of that same person. At 5 months, you can see the scar in the middle and there's no HS present. Okay. And the preoperative image is on the right-hand side. So moving on to the next slide. If you come in to see a physician armed with questions, it'll be very, very helpful for you to help set expectations for what you could and hope to accomplish from surgery. And I think this is the most this is what I'd love to hear you ask, not me, but other people. I think will be really helpful for you. These are my goals. Can you help me accomplish them? That's a big one. If someone comes in to see me and we are on different wavelengths as far as what they want and what I feel I can provide for them, we spend time really focusing on making sure that we're in the right place with the right goals before we embark on this journey. And sometimes it does take some time. Will surgery be in the office or the operating room? Will the wound be opened or closed? What type of wound care do I need? Will supplies be sent to my home? That's something classic that I arrange for. Do I do my own wound care or will a nurse come to the house? What will the pain be like and how much medication will I get? How long will it take the wound to heal? When can I return to work? Will it come back? And will I need more surgeries? So what are other ways you can make your surgery a success? Well, find the right surgeon or physician, continue medical therapy and work with a dermatologist. There's a rare case, a rare situation where I have people with HS who have very localized disease and are not on medical therapy, but for the most part, it's the combination of all of those modalities that work best long-term. Don't stop the biologics. And this is hard because there are a number of surgeons even out there who are afraid to operate on biologics we have good data for biologics in HS. There's no negative consequence from that. Frankly, we've been operating on biologics or on patients who are on biologics in other disease settings for a very long time. So I see no issues with this at all. Preventative regimen and lifestyle modification. If you can identify some of your triggers and work on modifying them ahead of time, that can of course help long-term. Stress management. We know that stress is a big contributor to inflammation, and then diabetes and smoking also drive inflammation, as we know. Most importantly, ask for help and support and be patient. This is scary, but what I find is that most of my patients, by the day of surgery, they're excited. And here's a picture. This was taken during COVID. You can see the cloth mask, but waving. They wanted a patient, a picture. A lot of people take selfies and have a good time with it. But get excited. We want you to feel good about this. If you don't feel good about it, it may not be the right time or the right space for you. So in summary, surgery can be successful if we set reasonable goals and expectations, focus on your personal goals and what the experience will look like for you, and don't focus on recurrence rates, because we know that this is a progressive, or it can be, not always, but it can be a progressive disease. We know it is a systemic chronic disease. So if we focus on recurrence rates, the reality is that surgery may not be the best tool when we think about that, but we know the tremendous impact it can have on quality of life. Thank you very much.
We really appreciate you and for providing us with so much information about HS and surgery. We have a few questions that have come in. Do people tend to get covered or approved by insurance for surgery?
The answer is yes, but you have to advocate and push. Okay. So if a physician office comes back to you, I'm gonna have a lot of people calling me tomorrow and yelling at me for saying this, but if a physician office comes back to you and says it's not covered, the reality is really question them about what codes they're using for this. Okay. Because the way insurance coverage goes for procedures is that for pre-approval, for people whose insurance requires pre-approval, the physician will say, well, I'm going to do this surgery and I'm going to use this code. And they submit the code to insurance. Insurance says yes or no. There's a large number of codes that can be used. There are codes that are specific to HS. The codes are a bit archaic. Let's go back to what I talked about before with the surgeries that were first invented, 60 to 80 years ago. For example, that Pollock procedure. The codes that we have right now reflect that. And the way that healthcare is right now, it is going to be a very long time until we can have specific HS codes that resemble what we know and what we do in the operating room. And I promise you, there is a group of people, especially with the HS Foundation, which I'm a board member of, we are actively working on this, because the reality is our codes don't match what we do. So at times we have to get creative. It also means that sometimes we have to use different codes, such as benign destruction of a lesion. I know that sounds very scientific, but benign destruction of a lesion that measures 0.5 centimeters to 1 centimeters, or 1 centimeter to 5 centimeters, for example. So the bottom line is that there always should be something that is covered. CO2 laser I want to just mention that for a second, because that's a bit more tricky. Going with the theme that CO2 laser can be used in a number of different ways, in the excisional way, in a refractory way. But the reality is there are still codes that can be utilized that could work instead of that. So a physician who's really savvy with, I've never had a problem getting a procedure covered for a person with HS.
Would you recommend laser hair removal for early mild HS?
That is a really good question. So I use laser hair removal in a couple of different ways. Um, I use it for preventative purposes. We don't have great data yet to support this. But if we believe, which we do believe, that HS is a primary disease of the hair follicle, my logic is if we can destroy that hair follicle, it won't be a target for that inflammatory response. So especially in my younger patients, I'm a big advocate of trying the laser hair removal. The reality is that if you never know if it's going to work. It's really hard to study. And I say to them, the worst thing that happens is that you don't develop HS in that area, and you don't have hair in that area if you didn't want hair in that area. Okay, so my teens especially, or my I see a lot of people who present to me after the onset of puberty. I'm a big believer in going and getting it done. The studies that we have for the use of lasers in HS are focused on the YAG laser. Not everyone has access to the YAG laser, and this is a space where insurance does, that is, I'm going to exclude that as a surgery that I talked about before, but surgery does not regularly cover the use of a laser hair removal or the YAG laser. From an access standpoint, if you don't have the money to utilize towards that, and it can be a lot of money, don't put yourself in a bad financial situation. Do laser hair removal. Those lasers are similar. They're killing the hair. I recognize that by me saying that, it could be viewed as very controversial, and I don't want to drive you into a different space to get care. What I'm trying to say is, if you don't have the financial resources to pay for this, to go through a dermatologist, and you're just trying to kill the hair follicles, try basic laser hair removal. And I've had a lot of patients be very satisfied with that. So that's one space to use the lasers. The other space, and I think this might be where the question was getting at, was for mild disease. We do know that passes of the laser at the right settings going over mild disease can be very effective at controlling inflammation and controlling disease. For something like that, that is best done in the hands of a skilled dermatologist who has all of the knowledge about the different lasers, the different settings, how many passes to do, and that can be very helpful. By the same token, if you have mild disease, for example, an isolated tunnel or something like that, you may end up with a better outcome by undergoing a small clinic-based procedure. So I think that's a really good discussion to have with your physician about which would be most appropriate.
Thank you so, so much for everything today, Dr. Goldberg. It has been wonderful to have you here. Thank you so much, everyone, who has come for the third day of the HS Awareness Week Virtual Summit. I really appreciate it.